Hello, everyone, and welcome to our Pacific Northwest Children's Initiative virtual event. Today, we are bringing together a group of people who really want to see big changes in the way we treat kids for cancer. So thank you for being here to learn about the game changer that is the LLS Children's Initiative. I really want to thank each of you for taking the time to be with us today. And I hope you all received a little special surprise for you at your homes today and are enjoying that as well. I am Ronica Norvell. I'm the Director of Advancement for the Pacific Northwest region at LLS, and I will be moderating the event today. So I'm going to start with a few housekeeping issues. So for those of you who have joined us for events like this before, for in-person events, obviously this is a little different. This world that we're in now, it really allows us to learn new things like how to do virtual events. But as you know, sometimes technology has another idea. So if anything goes a little sideways today, just please bear with us. We really appreciate it. We have everyone currently on mute right now in order to just cut down on background noise. So there will be a few times that we would love for you to participate, like in the icebreaker question and also the Q&A. So if you need a little primer on how to unmute on a computer, you hover over your picture, and in the top right corner, there's a mute button and unmute button. And then on your phone, in the bottom left corner of the screen, there's a microphone. We also would love if you would keep your camera on during this time, just because we really love this kind of community building part of being able to see everyone. And that is great. Also, if it comes time, when it comes time to ask questions, if you'd rather not unmute and ask questions yourself, feel free to pop those in the chat and we'll ask them for you. Please note that this is also being recorded. And that is the end of the housekeeping items. And I promise things from here on out will be so much more interesting. We have a great event planned with Dr. Sohail Mishinchi, who is helping to lead the Children's Initiative from Fred Hutch, and also Julie Guillot, a pediatric cancer parent whose son was treated in Seattle. But first we're going to hear from our Executive Director in the Pacific Northwest region, Jamie Kovnes. So Jamie, I'm going to throw it over to you.
Thanks, Veronica. And I'm so happy to see some of you I've met, some of you I will be meeting. But I really look forward to working with each of you to further the mission of the LLS, bringing cures, hope, and support to our blood cancer patients and their loved ones. We're so proud of the ways we're already doing this in the Pacific Northwest. So when COVID-19 hit, and for those that don't know, I started on March 2nd, so right when it all hit, so I was there for it with LLS. We were one of the first organizations to step up and help people who were hit with the double whammy of a cancer diagnosis during a global pandemic. So in our Pacific Northwest region alone, we helped almost 500 people meet their daily needs and awarded over $122,000 for non-medical expenses. Last year, our patient support team awarded over 2,600 grants totaling more than 2.6 million for blood cancer patients right here in the Pacific Northwest. And currently we have 9 LLS-sponsored research grants here in our region, several of which are part of the Children's Initiative. So we're so excited you're here with us tonight to learn about the Children's Initiative. This worldwide project is going to revolutionize the way kids are treated for cancer, and it's being led out of the Pacific Northwest, and we couldn't be more proud. So I hope you're proud too. We're building on the successes that we've had with the Beat AML campaign that started with Dr. Drucker at OHSU in Portland. And now the Children's Initiative is taking what we learned from Beat AML and applying it to pediatric acute leukemia. And the leadership is right here in Seattle at Fred Hutch and Seattle Children's. So together we're going to accomplish the goals of the LLS to better support patients and to find cures. So thank you again for being with us tonight. And I am going to turn it back over to Veronica to help us all get to know each other a little bit.
Thank you, Jamie. Really appreciate you being with us today to kind of fill us in on what's going on in our region and how we're making a big impact. When we do events like this in person, we really like it because we get to know everyone a little bit better. There's some mingling. So we wanted to try to do a little bit of that still today and get to know each other. So we have a icebreaker question, and we're gonna move through it pretty quickly, just because we definitely want to give Julie and Dr. Mashinchi as much time as possible to share their inspirational story with us. But so everybody will have about 30 seconds to answer. And please don't make me be the bad guy if you were a person who normally goes long. Just be sensitive to that. And what I'm going to do is I'm going to go through and call on people, and I will go alphabetically by first name, like your name is on your screen there. So I will start, and as a reminder, the question is, if you could wave a wand and instantly be an expert at something, what would it be? So my answer is that I would really love to just instantly be an amazing pianist, just to be able to sit down and play beautiful music, and just for me, not any kind of concert or anything, but just to have that lovely thing that I could sit down and do. Next, I'm going to throw it to Allison, who works here with me at LLS as one of our vice presidents.
Thanks, Veronica. Hi, everybody. So happy to be here. So happy to see all your faces. For me, I would want to be a baker because I love sweets, and I know it's such a precise, you have to be very precise in measurements, and I just don't have that talent or the patience. So I would want to be a baker and enjoy all those yummy sweets.
Great. Well, we'll know where to come over when you get that special power. Next, we're gonna go to Angela Taylor. Angela, what about you?
Hello. Thanks for inviting me. Gosh, I think that that question could change quite a lot throughout the week, if not the month. I think maybe right now would be to try to find a way for everyone in this country to get along a little bit better.
Oh, that would be a great magic
Really
wand.
idea. Really ideal.
I think we could all be on board with that. Thank you. Okay, next we're going to Fred and Sherry Pond.
I think I'm unmuted. I will answer first. I can't give you one answer. I actually have two. One is for myself, and that would be to be a scratch golfer and to be able to master that game that drives me crazy. But my more altruistic one would be, I would love to be a bioscientist and understand a little bit, or at least hopefully a lot, about what goes on with COVID vaccines or with cancer treatments and all that stuff. This stuff that you guys, the doctors and people, are amazing at, that I just can't always grasp.
Okay, I love to read, but as I get older, I'm having trouble retaining what I read. So I would love to learn how to read a little bit faster and retain more of what I read. So
That's great. And Fred, I think all of us are ready for a COVID one to be waived. So we all feel you on that one. Okay, next is Jamie Kovnes.
I'm back up. Well, I think so. I love to travel, and so I would love to be able to speak and understand all languages. So that would be my superpower. And maybe I'll make it altruistic as well, like Angela, and then like I could help with communication for everyone in the world.
That is great. I feel like that's one of those ones that come up to when people say, what's your superpower that you would want? So I love that one. Okay, next, Judy Laferno.
Hi, mine's kind of funny, but I sing better when I'm alone, but I don't think I sing terribly, but the other problem is I get the lyrics wrong all the time. And I'm one of those. So I would love to be able to sing beautifully and not be self-conscious, but also get the lyrics correct.
That's great. Maybe we could partner. I could play the piano and you could sing. Could be a duo. Okay. Next, we're going to go to Rebecca. Rebecca.
There we go. Sorry about that. I would love to be able to be an expert at identifying trees. I'm a naturalist and by trade, I guess, but trees are my weakest point. So I would love to be able to just walk into the woods and know all the trees.
That is great. And then I would love to go for a hike with you and be able to do that. That would be so fun.
It would be.
All right, Dr. Mashinchi, it is your turn.
Well, if I could wave a wand and do something that I always wanted to do, is to learn a musical instrument just like that. At this point, doesn't matter really what, but drumming was something that I always loved to do, just never got a chance to do it. I even tried to get my son to do it in proxy, and I was not able to get him interested. So playing drums would be it, I guess.
We're going to have a whole band pretty soon here.
Yeah.
That's great. Thank you. Okay, we're going to go to Julie Guillot.
Well, I asked to go after Sohail because actually, if I could be an expert in anything due to the life experience I've had, I'd love to be an expert in childhood AML and childhood leukemia, but I'm going to let Sohail keep his crown as world's leading childhood AML expert. And if I could wave my magic wand, I would have the expertise of a Warren Buffett. So I can make loads of money and I could fund everything that needs to be funded and put childhood cancer to bed.
Oh, Julie. Yes, I love it. Thank you. Okay, next is Suzanne and Tom Hornish.
All right. If I could wave a magic wand, I would want to be able to dance. Like being on the Dancing with the Stars is one of my dreams. Not sure with him, but.
And for me, actually, Julie, when we were talking before this started, I had the same thing. I want to make a lot of money to be able to give all the money away to help everybody. But I've come up with a little bit more lighter one, given some of the thoughts. I decided I'd really like to be an expert at basketball and an NBA professional because I would be a lot taller then.
There you go. We have so many fun things. And I think somehow we missed Rob Schick. Rob, you got out of order on here. We'll go to you next.
It's funny, this whole music theme. So I've always wanted to be a guitar player, but I've never had the time. First in school, then raising kids and work and everything. But what better time than the start of this pandemic and COVID and being isolated and can't go to the movie theater, can't go to dinner, can't do anything. And my wife on my birthday this year walked in with a acoustic guitar and said, "Now you have no excuses, you got time." I will never be an expert. I know that so far. It's not easy, but the process is very fun. And when you have time and it's relaxing and I wouldn't want anyone to listen to me play, but I enjoy the process. That's great. So you can make your magic dream come true. That's nice. Or at least yeah. And Will Winter, what about you? What are you waving your wand for?
All right. Well, so first of all, guitar is a beautiful thing. It's actually super easy to learn and you have no excuse for sure. So no, if I had to wave my magical wand right now, what I'd like to be an expert is in the mind of a teenage daughter. So totally need lots of help with that. So done. But I'm not sure I really want to be that.
I'd like to change mine to that as well. I got two of them.
Hey.
Uh, yes, I think all of us, I have a 5-year-old at home. I think all of us with kids at home are needing a little extra skills in that department right now. All right, and we do have someone on the phone too. I think it's Kat. I don't know if Kat wants to participate, but just want to give you a chance if you want to. Just give you a minute to unmute if you'd like to, Kat. Okay, well, we're gonna move on then. Well, great. So thank you guys so much for sharing. I just think that's such a nice way to get to know each other a little bit. Also just gets you ready. Now you know how to unmute when it comes Q&A time. You're ready to go. So thank you so much for sharing a little bit about you, and thank you for being here. So now I'm going to turn it over to Fred and Sherry Pond, who are going to introduce our speakers. Fred and Sherry are supporters of the Children's Initiative and are founding members and volunteer leaders for our Cancer Cure Council in the Pacific Northwest. So Fred, Sherry, over to you guys.
Thank you, Veronica. Appreciate it. And like she said, we are supporters of the program. We were introduced to it about a year and a half ago at a C3 dinner back in the days when we could get together and have a dinner and drinks and share ideas. And Dr. Gwen Nichols and a doctor from Children's Hospital in Seattle gave a discussion around the Children's Initiative. And so then we have been supporting it financially through our C3 support the last 2 years. So it is close to our hearts, and we believe strongly in it and want to support it. With that said, I want to do a quick introduction to Dr. Sohail Minshi and also to Julie Gio. So Sohail is, as was said before, at Fred Hutchinson. He is a pediatric hematologist and oncologist, treats children that have high-risk leukemias. He is widely regarded as an expert with targeted therapies for patients with acute myeloid leukemia. He also deals with a lot of stem cell transplants for pediatric leukemias and in the management of post-transplant relapses. And he is also the target and biomarker lead for the LLS initiative, and hopefully he'll explain to us what the heck that actually means, as I'm not sure I'm technical enough to know that. Julie, she is a former technology executive and advocate with a passion for accelerating progress in the treatment of childhood cancers. Following a 4-year struggle across 3 hospitals, Julie lost her 9-year-old son, Zach, to AML back in 2014. This deeply impacted her, and she is now driven and fully engaged as a full-time volunteer as the chair of the Pediatric Partnerships and Outreach for the Children's Initiative. So Julie and Sohail, I want to turn it over to you. Thank you for giving your time and being a part of this tonight, and we look forward to learning from you. Turn it over to you now.
Well, thank you, Fred. And I mean, you don't have to thank me about, for giving my time. I really want to thank all of you for giving your time tonight. You could have been doing 1,000 different things. And I really want to thank you from the bottom of my heart for joining us tonight to learn more about the Children's Initiative. Again, I'm Julie Gio, and I live in Austin, Texas, but my body is in Austin, but my heart is in the Pacific Northwest. And you'll hear more about why in a few minutes. It's very close to my heart. So I wanted to first, before I talk to you and share more about the Children's Initiative, just want to share a little bit about my son Zach's story. And so we were kind of a normal family. Living in Austin. We were living on the lake here, and really, had a great life. I am like Fred said, a former high-tech executive. I was a consultant for Accenture. I worked for Dell for many years, and I had kids, kind of later in life, and so I retired from that and focused on my kids full time. And, you know, we were just kind of that normal family. And yeah, I probably was a little bit of that mom who wanted to do everything right. And, you know, we ate all organic food. We had no cancer history in the family. Next slide. But one day, my son, when he was 5 years old, well, really over a course of a few months, started developing some weird symptoms. He was getting these bruises on his shins, and he got this little sore on his tongue, this little ulcer at one point. And then, you know, I was really kind of concerned. He was losing a little bit of weight, and I started Googling, you know, like we all do. Except in this case, what came up every single time was symptoms of childhood cancer. And of course, I mean, you're like stunned. And I didn't tell anybody in my family, but I really watched him. But we all do that, right? And it tells you have some catastrophic disease. But I kept watching, but 1 week, his symptoms really escalated. He had a headache every day for a week, and this is in a 5-year-old. And he had very high fevers, and he's a cough, but he didn't have any other respiratory issues. I took him to the pediatrician 3 times that week, and on the 3rd visit, I asked them for a blood test. And this was on a Saturday. 2 hours later, they called me back, and they said, "We think that Zach has leukemia." And I remember just being doubled over in my kitchen. It's like somebody just took their fist and like punched you in the gut. But after that, I kind of recovered for a second, and I told the doctor, I'm like, you know, wait a minute, isn't childhood leukemia pretty treatable these days? But what I didn't know is that there are multiple types of childhood leukemia, and some have a much worse prognosis than others. So unfortunately, Zach was diagnosed with acute myeloid leukemia, or AML, which today remains one of the poorest prognosis childhood cancers. And, you know, when you think about childhood cancer, you know, I remember standing in my kitchen one time, just a few months prior to that, and when one of those St. Jude commercials came on. And, you know, you see all the pictures and they look very much like this. You know, childhood cancer is terrible, but, you know, look at the smiling cherub faces. And there was a lot of time like that when, you know, Zach was happy despite being in the hospital. But what I didn't know about AML, and we can go to the next slide, is that it is a very aggressive leukemia, and the treatment is absolutely horrendous. We rely on decades-old, highly toxic therapies. And so Zach endured round after round, month after month in the hospital, undergoing what I call maximum a human can tolerate chemotherapy. And I apologize for some of the pictures, but you know, the chemotherapy at some points would burn Zach's skin from the inside out. You know, this big picture of him in the bed with all the leads on, that was 105-degree fever that no matter what we did, wouldn't break for an entire day. His head swelled up from one chemotherapy agent that he took. And so this really went on. You know, these treatments can often put these kids in the ICU. This is just sort of normal for AML patients. And even a certain percentage of these kids actually die from the treatment itself. And so I didn't know this about AML, but I mean, there were times, and I'm not a lot of things, but I'm a pretty tough person. There were times when I literally thought that I would collapse in the room due to the complications. And he endured this for 4 years. Zach, if you know anything about bone marrow transplants, Zach actually endured 3 bone marrow transplants, 2 in Dallas, and we also spent some time in Memphis at St. Jude. But we also ended up coming to Seattle for at Seattle. I always brag on them because it makes me cry. Because they were the only ones willing to take on Zach's hopeless case. And they fought for Zach for 1.5 years and tried everything under the sun and never gave up on him until, you know, that last day. And actually they were the ones, and Dr. Sohail was actually the doctor who I signed the papers with him for Zach's third bone marrow transplant. And so Hale really fought for Zach as we were trying to really, you know, pull a rabbit out of the hat for him. Next slide. We can go up. So, you know, Zach did get that third bone marrow transplant, that Hail Mary. He was a really tough kid and he could take the therapy. And he wanted to try. He said, Mom, I want to live. But unfortunately, after that third transplant, with all of those years of chemotherapy and all of those cumulative toxicities, unfortunately, a couple of weeks after his third transplant, Zach passed away in the ICU of liver failure as a complication of transplant. And I just, I mean, there are no words that can convey to you the profound impact that this has had on me. I remember walking out of the hospital last night, that night that he passed away. And after you have given everything that you have for 4 years to try to save your child, and then it's just all over. And I remember walking out and I'm looking at the floor and I'm like, this can't be over. And then at that moment in time, I said to myself, this is not over. Next slide. And so like many of you, obviously cancer is a profound life changer and you can never look at anything else the same again. And so I got involved with fundraising at first for the Fred Hutch. And so I am, like probably many of you, I'm a big supporter of the Fred Hutch and of Seattle Children's, and started a lot of work there and learned more about Leukemia and Lymphoma Society. But when I learned about LLS's Beat AML initiative, I actually, you know, that kind of got my head perked up and I was like, wait a minute, we need this for kids. And so I actually went to Dr. Sohail one day and I'm like, Sohail, what is the Beat AML project in kids? And so as early in late 2015, that picture down there where I'm with Dr. Lou DeJaneiro, the CEO of the LLS, I, with Sohail down there at the bottom holding that little paper, we went to Dr. Lou in the early days and pitched a pedal master trial, a children's initiative for kids, sort of in the model of Beat AML. And so that is how I kind of got involved with all this. You know, I was constantly looking for what can I do? You know, what skills could I bring to the table? And so that's how we ended up here, the Children's Initiative. And so next slide. And so that's a little bit about my story, but you know, just coming to you and telling you about the Children's Initiative, I always like to kind of open the hood and show you a little bit more about why, you know, kind of start with a why do we need something like this? So Sohail and I wanted to kind of tag team and talk to you about sort of the current state of childhood cancer and childhood leukemia, and really what our key challenges are, so that you kind of get an understanding of why do we need to do all this. So the first thing I wanted, you know, if I were just gonna hand you some things to take with you, I do want to emphasize the fact that obviously we have made tremendous progress in childhood leukemia, especially with the emergence of the CAR T cells. That was a total game changer in childhood ALL, the most common type of childhood leukemia. But still, you know, despite our progress, cancer continues to be the #1 most common cause of death in kids by disease. So it's the #1 disease killer still. And still with all the progress, leukemia is still at the top of the list of the childhood cancers that kids die from. It was recently edged out by brain tumors, but virtually tied still. And still we have kids like Zach who are dying from some of the rarer leukemias like AML. So about 20% of kids with leukemia get AML, and there are other types as well. And it's still very poor prognosis. And the one thing that I can definitely say about childhood cancer is it is extremely traumatic to young families. You are hitting people, couples in their prime earning years. They often have multiple little kids. My daughter actually learned to walk on the bone marrow transplant unit. My kids grew up, my Zach siblings grew up in the hospital. Those are their early memories. So it's when a kid gets cancer, the entire family has cancer. Very impactful. And then also too, I know it may sound strange, but we have very, very few FDA approved drugs in childhood cancer. All the FDA approvals are in adults, and kids just kind of use the drugs. And as I said before, you can see with Zach's story, our current drugs are decades old and super toxic. There was one drug that Zach took, in fact, in bone marrow transplant that was so toxic that I had to give him a bath every 4 hours to wash it off, or it would burn his skin. And this was like a drug developed, I don't know, Sohail probably knows, like back in the 50s or 60s. We're still using this. These are our mainstays. And so, you know, also too, yes, our survival has gone up in childhood leukemia, but just because you survive doesn't mean that you thrive. See this guy over here with the birthday cake to the right, his name is Brennan Simpkins. And like Zach, he had 3 bone marrow transplants, but actually survived his AML. But I've actually visited Brennan a couple of times in Georgia, and he struggles with seizures, growth issues. He has severe cognitive impacts. He's very behind in school. He's very sensitive to the sun. I mean, and he had cataracts already, and he's a teenager. And so survive doesn't equal to thrive. So we have to do better. Next slide. So, you know, what's kind of holding us back? So I'm going to go through this really quickly, but this is where I'm going to let Sohail kind of talk you through our current challenges and kind of the things that are in our way. And the first point is that, you know, leukemia, and even if you just take like AML, it is actually not one disease, but it's actually a group of diseases. There are many subtypes. And so our one-size-fits-all therapy, look, the one-size-fits-all didn't work for Zach. It may work for other kids, but not for Zach. Next bullet. And so Sohail's really going to talk about this too, is, you know, AML, he'll tell you is really a disease of older adults. But all of our drugs were developed for adults, and they could just kind of trickle down to kids, and kids are not biologically little adults. So the hand-me-down therapies, while some of them are great, some of them don't have any applicability at all. And so kids are kind of left with these oversized clothes to wear, and they just don't fit. Also, and Sohail talk about this, pediatrics is extremely disadvantaged in terms of funding and focus. All of it goes to adults because let's face it, you know, even though cancer is the #1 disease in kids, in terms of death, relative to adults, it's a much smaller population. There's no profit in it. There's risk in it. And so pharma really shies away, and we don't get as much funding and focus. Next. Also too, you know, because funding is an issue, we don't have, and this is where, you know, this as a sort of an engineer process person, in childhood cancer, the way we are structured and the way our trials are structured are not optimized. So we have some slow processes and really infrastructure issues that are slowing down even the drugs that we do have to test. They're very slow moving through the system. So we have some issues around process, and then we also have these crazy silos. So really think about it. Research often takes place in individual institutions. Sometimes they like to hold their data close to their vests in order to get published. Institutions run their own clinical trials, and that, you know, there's some merit to that, but at the same time, sometimes imagine if you had, you know, 100 different trials running at one time. That's going to get all your patients are diluted into those trials. And so you end up, these trials take a lot longer to finish. So we have some silos that we have to overcome. And then also, I already kind of alluded to the funding. But let me kind of turn it over to Sohail, who can also talk about some of the challenges that we have.
Thank you, Julie. I think that one of the critical questions that comes to really dealing with pediatric leukemias in this case is how are the discoveries made in pediatric leukemias, and also where the drug is developed. If you can go to the next slide. So by looking at the, so this is basically a very simple representation. The blue bars that you are seeing is simply incidence of acute myeloid leukemia, AML. This is the leukemia that Zach had over age range. And what you can see is that majority of the patients with AML are in the older age range. Actually, more than 80% of all AML occurs in older adults, 60 years and older. And because of that, virtually all of the discoveries and treatment therapeutic development, all the drugs that are developed, are focused on developing these drugs in older adults. And the assumption is that, well, AML is it's the same disease regardless of age. And if we develop treatments in 60, 70, 80-year-olds, then we can use it in kids. And that assumption that it's the same disease, but it occurs just less frequently, is really not valid. You can just imagine that a 6-month-old with AML, it's unlikely that it's the same disease as a 60-year-old. So from that standpoint, it makes a lot of sense, but that's exactly how it is perceived. And actually, when we initially went to NCI for funding for our genomic testing in pediatrics, we were told that while we're funding the adult study, we just wait for the results and you can use it in kids. The inset, the smaller figure that's inside, it really demonstrates that some of these targets that are really being used for treatment development, how vastly it's different in adults versus children. So what we're looking at here are the 3 different mutations. The green is the mutation called DNMT3A, and then the yellow and purple are IDH2 and IDH1. These mutations, they really occur quite at high rates in older adults, and overall more than half of all adults, older adults, they have one of these mutations. But when you look at the younger patient, less than 16, they're just not there. None of our pediatric patients have even any of these mutations. So you can imagine that if a treatment is developed, a targeted treatment is developed for any of these mutations, would not really have any utility in our younger patients. Next slide. So this is a great example. We actually had this company come to us. Oh, we have this new drug that we just got FDA approval for IDH2 mutation. We'd like to run a pediatric AML trial. As unfortunately, as I showed in the previous slide, in our pediatric age range, we don't have a single patient that could benefit from this drug because we don't have any patient with this mutation. So you can see that the treatment that are developed in older adults, they really have virtually no utility in our pediatric patients. And as a result, we really need to really rethink the process. How do we develop these therapies for adults versus pediatrics? And without having a really meaningful discovery data set in our pediatric patients, the same way that they've been doing it for decades now for older adults, it's really difficult to develop targeted therapies if we don't know what the targets are. And the other thing that Julie mentioned, this idea of one drug fits all, and that's exactly how we've been approaching AML, that we do these randomized trials that we give the standard of care, which was really developed more than 40 years ago, that hasn't really changed anything, with and without an experimental drug, hoping that one experimental drug that we're adding is going to substantially change the outcome. And I can tell you in the last 30 years, we have not had a single drug that has shown any benefit in that experimental arm. So we are stuck in this sort of ongoing battle that we keep doing these large trials without showing any benefit, because this approach of trying to find that one drug that cures all AML, it's really a losing battle. That unless we're able to identify individual subsets of patients with their unique targets and going after them, it's going to be very difficult to make any gains. So the idea of finding one drug that makes this huge jump from relapse to complete cure, that has not worked out well. I think that we really need to really rethink how we're approaching. And with the new data that in hand, we are really highly optimistic that we are at the point that we are going to be able to make those gains. So I think that that really shows that really looking at a pediatric leukemia differently than what we've been doing over the last several decades. That these are not just that's the same disease. It just
So
occurs
Hell,
less
we can't
frequently.
hear you.
Oh, hello? Can you hear me? Oh, can you hear me?
Yes, we can hear you.
Yep.
Yes.
Sorry, it might have been me. That's the technical issues that Monica refers to. Go ahead,
Okay.
Sohail.
So anyway, I think that overall, it can go to the next slide. I think. So anyway, so overall, it's really the whole idea of trying to come up with a mechanism that we can more appropriately identify targets in younger patients and develop therapeutics, or if there are drugs available appropriately to bring it for the repurposing. So Julie, I'm gonna return it back to you so you can take it from here. Okay.
And I think there's one other point that wanted to make as well, because it really ties into the Children's Initiative. So some of the drugs that pharma is developing, they just don't fit kids, but there are some that do fit. And of those that do, we also have tremendous issues with actually getting the drug company to give the drugs to us for the trials. Isn't that right, Sohail? And sometimes there's a years-long lag. I think there was one study recently that showed it takes a drug 6.5 years on average from the time an adult has access to the time a child has access. So our kids are really at the end of the line, aren't they, Sohail, to try some of the drugs?
That is true. That's true.
And so, we've kind of come to you with a lot of issues. And so, we do have significant barriers, but I think one of the things we also wanted to leave you with is that we also have, we're really living in a time of accelerated discovery in cancer, and we have a lot of opportunities to take some of these barriers and just mow through them. So of course, and I think your Dr. Drucker there in Portland kind of led the charge. We have many new targeted therapies that are rapidly emerging. We do have the opportunity now, when we discover targets in kids, sometimes those map to drugs that were developed for other diseases. So we can actually try some of those drugs in our kids when there's a shared target. Also, you hear it on the news all the time. We're living in the age of big data. And so with all of these, with access to genomics and really being able to understand the biology of the cancer, and with 3D visualization and different analysis tools, we can really begin to really unravel the biology of the cancer so that we can specifically target the patient's unique cancer. Also, too, I did want to point out, remember when I talked about the silos? I do think that we are living in a time right now where people are really recognizing that these silos for research, silos from data, working in your little corner with your lab just isn't working. And that we really need hospitals and researchers and even foundations to work together and collaborate to really attack and realize some of the big opportunities that we have. So we do have openness for collaboration. Also, too, we do have an openness to improve some of these broken processes that we have and to rethink, how we do research and how we do trials in kids. And next bullet. And obviously, we've already talked about how we have key learnings in the VAML master trial. Now that we have sort of lived through that, we can begin to apply those key learnings in pediatrics. And also, too, we have some good news because there have been some recent policy changes and funding that has been directed toward pediatrics that is really compelling some of these pharmaceutical companies that they have to test their drugs in kids. And so also too, we know that this precision medicine model can work, and it really offers great hope. But it does require sort of a new way of thinking and a new infrastructure. So before we move on, Sohail, are there other opportunities that you're seeing to really address these challenges that makes this sort of the right time to rethink things?
Well, I think one of the critical pieces that we have in place right now that we did not have even as of a couple of 3 years ago is the deep knowledge of the AML and leukemia, through the sequencing efforts. One thing that there's been really a paucity of information on pediatric cancers until recently. And I remember Bill Woods, who's one of the our AML gurus and certainly my clinical mentor. He used to say when there was a complex patient that we were dealing with, Sohail, this kid is trying to tell us something, trying to teach us something, which is just not smart enough to really get it. And now we are at a point that we are able to learn from our patients in a much more, much deeper way, and to a point that we're able to go back to the patient's genome and transcriptome and trying to link what's going on with a particular mutation or translocation. These are information that's really helped us treat our patients, and we've had some really substantial successes when we identify what it is that's driving that leukemia. We are able to make gains in that. When we treat everyone the same, we look at it, we say, oh my gosh, our survival is 50%. That's basically just flip of a coin. But by knowing what drives the leukemia, that really helps us to bring in new treatments that we would not have been willing or able to try. This is, the Mary Stewart's here, and Javiana was certainly one of our very first patients that we used a drug that we had not really used before because of the knowing what the leukemia was doing. We have a great, I don't know if this is the next, can I look at the next slide?
Sure.
So I wonder if this is the one that, this is actually an incredible success story. This is actually, I pulled it out. I was not expecting to really see this result. This is a group of patients. This is what we call the 6-9 translocation. And this is the same group of patients that are treated in 3 different clinical trials. In 1990 to 2000, presence of the translocation, this is before we knew what the makeup of the disease was. This group of patients, their survival was less than 15%. And so over in the following decade, because we had just discovered some of the genetic changes, these patients, we took them to transplant. At the time, we didn't have anything else. The survival went up to 58% from 14%. And most recently, this is the last trial that we just finished, survival for the exact same group of patients was 94% because we were able to incorporate a FLT3 inhibitor, sorafenib, along with taking the transplant. So we basically, although this is a small number of patients, we were able to substantially change the survival for these patients from less than 20% to uniformly curable. And we have a number of these subsets of AML that if we're able to pull them out and line it up to available or therapy or something that we can develop, then we can really move the ball on this. So it's just a matter of really learning about the disease and trying to really bring in treatments that would hit that target rather than just trying another chemotherapy that we know is going to fail. So I think that the opportunities are there. We've generated a massive data set for pediatric leukemias. It's a matter of trying to learn from them and try to move forward with some of those treatments. To whether the treatments are available, we can move it into the clinical trial. Otherwise, to really put resources to actually develop treatments for pediatric leukemias. Right now, really what we are doing is that we're hoping that we'll find a drug that is developed for some other disease for adults that hits the same target. Short term, that's ideal, but long term, we really need to put the infrastructure in place to actually develop therapies for some of these targets that we're discovering in leukemias in kids.
Okay, next slide. And so, you know, we were talking about our magic wand, and you can just go ahead and tap through all these bullets, but we talked about the magic wand earlier, but what if we could wave the magic wand and we could develop more pediatric specific drugs? What if we could really maximize those existing drugs and get the drug companies to actually give the drugs to our kids sooner for clinical trials? And what if we could begin to actually tailor therapy to the child versus our one-size-fits-all model? And, you know, like Zach, he suffered so many of those toxic side effects. What if we could reduce those side effects by more specifically targeting the cancer? And what if, you know, some of those processes that I talked about, what if we could actually do a bunch of process improvement and cut the bureaucracy to really deliver precision medicine to our kids? And what if we could get more FDA approvals? What if we could do all of this and really to develop more curative and less toxic drugs for our young people? And what if we could do it both now and we could keep working on it going on? Well, I'm happy to report, next slide, that we can, and we actually are. And I'm really happy to tell you tonight about LLS's big vision around the $100 million Children's Initiative, which is really a kind of 360-degree multi-front attack on childhood leukemias. And really this is a very comprehensive plan. And the goal is for LLS is really bringing everyone together to work collaboratively to launch a precision medicine platform for our kids. And so really bringing pharmaceutical companies, the government, many hospitals together to really drive transformational progress. Next slide. So, you know, there's a lot to the Children's Initiative, and it's hard to explain it to you, but trust me, if you were going to take a checkbox and all of those challenges that I kind of laid out for you, if you were to put a check out beside each of them, the Children's Initiative is really tackling all of those challenges. And so what I wanted you to take away today is that you know, the Children's Initiative just has a few key pillars. Number one, so Hale talked about the need for expanded discovery. And so I'm happy to report that through the Children's Initiative, the Leukemia and Lymphoma Society is greatly expanding their pediatric specific grants. And this is really huge because we have difficulties, so Hale knows this, getting pediatric specific funding and research. So that is one area of focus. The other area of focus is around policy and advocacy. Not only does the LLS have a crack team in Washington, D.C. that's helping, they really help to drive some of this big legislation that's been passed in pediatrics lately, but also too, they are really doing something that you almost can't, remember the old Visa commercial, what was it, priceless? They are doing something that you can't put a price tag on. And that is, they are inside the FDA, they're inside the NCI, lobbying on behalf of our kids to actually deliver this new master clinical trial that I'm going to talk about. They are also actively advocating with drug companies to give us the drugs for the trial. And, you know, LLS is kind of putting a little bit of pressure. Gwen Nichols, one day she was at a big conference, and I swear this woman walked 8 miles that day. She walked miles, and it was meeting after meeting with drug companies. And Sohail was with her, where they sat down and they talked with drug company after drug company. And this is really tremendously valuable to our team, because sometimes drug companies won't even meet with our doctors. And the other pillar of the Children's Initiative is a multi-arm precision medicine master trial that will really put in place the very expensive and complex infrastructure it takes to deliver targeted therapies and precision medicine to our kids much faster. So those are sort of the key pillars of the Children's Initiative. Next slide. But if I were really going to describe the Children's Initiative to you, and again, it's hard to tell you in just a few minutes, but I do, one of my inspirations as an advocate is I am very much interested in speeding work that is strategic and that is going to have a very high impact. And so this Children's Initiative is definitely a paradigm shifter. We are delivering, it's sort of almost a rapid drug delivery platform. And so it is really going to change our standard of care in leukemias. Also, another key thing I want you to know is that, well, how does this apply to the Pacific Northwest? Well, the Children's Oncology Group hospitals, of which there are many in the Pacific Northwest, will be participating in this trial. So not only is it local, but it is also national across 200 hospitals. And the goal for it is to also be global in Europe, in Canada, Australia, New Zealand, so that we can get our answers quicker. We can run these trials faster. Already talked about the fact that it is very collaborative in nature, bringing together many hospitals, researchers, pharmaceutical companies, the government. It is also really child-centered. Today we kind of have this structure where, you kind of have the kid over here, but you have trial A, trial B, and it's just kind of standalone. But this new approach puts the child at the center. So when a child is diagnosed or relapsed, they will receive genomic testing, and they'll be routed and directed to the best fit trial for them. And also, to the goal of this initiative is to try to avoid the child having to travel to another town, that the trial will be available in their town. And if they do have to travel, LLS has a travel and expense fund to help that family. And the really cool thing about this precision medicine platform is that it is expandable. It is expandable to other childhood cancers other than childhood blood cancers. So it has the potential to really benefit many. And so, if I had to just sum it up, what is this all about? This is about, again, delivering less toxic and more curative treatments to our kids, leveraging the power of precision medicine and collaboration. So next slide. So Sohail can talk a little bit about this, but I want you to know that this is not a future thing. So research always you kind of think, oh, this is like years from now. But I want you to know that this initiative, it makes me cry every time I say it, but it has already changed the standard of care for childhood AML. This is a today thing. It is happening now. Previous to this initiative, many of our kids were not receiving genomic testing, which is a cutting edge. It is a cutting edge diagnostic tool that you really need to deliver precision medicine. Our kids were not receiving it. Thanks to the effort of LLS, every newly diagnosed child with AML is now receiving genomic testing, and that is a reality today as of August. The LLS has also already formed a huge international collaboration that includes your local hospitals. And I already talked about kind of this big collaboration. We do have numerous pharmaceutical companies that are engaging and are interested in participating. And we have our actual trial structure is in approval with a goal to launch in 2021. But I do want to show you, go back, see that picture there with the arrows? So who are the key architects? So this is the collaboration. So you can see there, Dr. Todd Cooper from Seattle Children's and Sohail there in the front. And also Dr. Drucker couldn't be there, but his Beat AML team was there as well. A huge part of the architecting and a vision is coming out of the Pacific Northwest. And so I hope that you're proud of it. It makes me feel better as being the mom of Zach to know that in his last days that we probably came to the right place for his treatment. So Hal, did you want to say anything else about the progress today?
So one thing that I want to really point out is that this is a vision that we had for quite a long time, to be able to have a big umbrella protocol that captures all of our relapsed refractory AML patients or leukemia patients in general, and to be able to treat them. Because one of the biggest roadblocks that we've had in developing therapies because of the fact that once patients relapsed, we were not able to capture them appropriately. And the number of patients with relapsed leukemias are so small that we were really not able to conduct required clinical trials to move a drug forward. And for the first time, we have been able to really put our vision into practice. And really the only way that we were able to do this was having a partnership with LLS. Because one thing that LLS was able to do really to say that they brought all the stakeholders together, whether you were part of COG, St. Jude, Sloan Kettering, or Boston Group, they all became part of this collaborative to make sure that we're able to do this. And the idea would be to really have a trial that every relapsed refractory leukemia patient would enroll on. They get screened centrally with the most advanced diagnostics, and then they would be allocated to appropriate clinical trial based on the target that they expressed. And that is something that was our really dream. And now through the LLS Children's Initiative, that is a reality. Our master trials has gone through and has already been approved, and we're starting the trial, our screening protocol in a matter of few months, and by next year we'll have this in really full swing. So really for the first time, we are going to have what we had envisioned for the last 10, 20 years. And this is, we needed a partner to help us take the next step, both bringing the drug companies as well as other academic institutions together. And LLS has allowed us to do that. So I think that we're one step closer to really making our dream a reality, and thanks to LLS Children's Initiative.
Next slide, we can roll. And so, one thing that I did want to leave you with is that you can look on here and see that this wasn't just something that LLS kind of hatched up in the back room. It is architected by the top experts across the country and even in Europe. And so this initiative is designed by top physicians and is endorsed by them. So I wanted to kind of pass that along to you. Next slide. And LLS, I do have to say, there was one quote by the chair of this whole initiative, Dr. Andy Kolb, and his quote was, there's no way that we could do this ourselves. And so the Leukemia and Lymphoma Society, as a neutral party, but a powerful and influential convener with a lot of expertise, a lot of connections, a legal team, a project management team, an advocacy team. They have great influence in the pharmaceutical arena. They are bringing all of this to bear for pediatrics. And there is one thing I did want to mention. You know, we've talked a lot about AML tonight. And so our Pedal Master trial will start with AML patients and ALL patients that share some targets. But the goal is for this platform to be rolled out for all pediatric blood cancers. Just starting with AML, because go back to that, it is probably one of our poor prognosis. It's one of our poorest prognosis childhood cancers. So starting with AML, but rolling out more broadly. So I did want to make that point. Next. So I really apologize for going over time. But if I had to leave you with a few key things, a few key takeaways, is that, you know, thanks to partners like LLS, we have made great progress in childhood leukemia, but we obviously have more to do. But we do have some very solvable challenges. We can accelerate progress. And the Children's Initiative is a big plan that can really transform how we treat these very difficult leukemia patients. And they have the horsepower. But, you know, we are sort of the horses and the power. You know, those of us who help support Leukemia and Lymphoma Society, I have made a substantial personal commitment to this project. And but it's going to take all of us, you know, helping to pull the wagon. But I did want to leave you just with one final thought that I always, you know, talk about, and it's a little homework assignment. If you've not yet watched the documentary, The Emperor of All Maladies, I highly encourage you to watch it. It is the history of cancer, and before your eyes roll back in your head and go, oh my gosh, no way. It is a very, very interesting documentary. And what you will see if you watch the history of cancer is that kids have really driven the majority of our major discoveries in cancer. They inspired chemotherapy. They were pioneers of the bone marrow transplant, of these new cellular therapies. So when we invest in our kids, we are really investing in everyone, because these are therapies that all of us can benefit from. So I just wanted to leave you with that. And here are some ways down below that you can help. We need help in a variety of ways. But I always like to let Zach have the last word. So I'll let you kind of click the little video and then we'll take some questions.
Hey, Zach, how you feeling today after the second chemo?
I feel great.
Seriously?
Yes, I'm going to get through this. And leukemia, if you're watching this, you're going down.
Seriously? Can you please tell everybody that we did not stage or rehearse this video?
We didn't stage or rehearse this video?
Okay, well, that was pretty good. All right. I think a lot of people are worried about you because it's a tough chemo. So you're feeling all right tonight?
Oh, yeah.
All right.
And leukemia, you're going to die.
All right.
Cut.
And with your help and with all of us working together, leukemia will die. So again, thank you. And I apologize that we went over time, everybody.
Julie and Dr. Mashinchi, just thank you so much. We want to be sensitive to everyone's time, and we will stay on and answer some questions, but if you need to go, we totally understand. But just wanted to open it up and see if there are questions that you would like to pose to either Julie or Dr. Mashinchi today.
This is Tom. I've got a question. So Hill, good to see you again. Julie, good to see you again too. I'm curious with the initiative, is it primarily focused on drugs for the targets, or is you had mentioned CAR T before? How much of the initiative will be CAR T? And I'm also becoming familiar with natural killer cells and how much that might be part of the initiative as well.
So Hill's working on some natural killers, I think.
Yeah. So Tom, really great question. I think that CAR Ts are certainly, they're a fantastic way of harnessing the power of immune system to go after cancer cells. And in fact, because of the with CAR Ts, actually, the path to the clinic and clinical trial is much shorter than some of the other therapies. So that's a really ideal. The question is that what are the targets that you're going after? Until basically now, right now, there's one CAR T that's been shown to be effective. It's a CD19 ALL. In AML, it's been much more complicated because of the fact that a lot of the targets that they express on AML is also expressed on normal cells. So to be able to separate them. So we do have a list of targets that are uniquely expressed on AML cells only, and not a normal hematopoietic cells. So we are developing some. There are a couple of other groups that are developing it. So it certainly is on the list of target therapeutics to move forward. So regarding natural killer cells, I'm sure you've heard of Colleen Delaney. So we're actually working with them to use natural killer cells to arm them and use them what we call a CAR NKs, that we actually arming natural killer cells with a mechanism to recognize leukemic cells. And this is something that we're growing these in from cord blood cells. So we're actually using cord blood cells that are just sitting around. So the company called Devera, they're actually taking cord blood cells, they're making NK cells, and then we arm them for AML. So I think that certainly is one of the options that we're approaching. We have one CAR T against the target that we're actually in the process of moving forward to the sort of a clinical trial stage, hopefully soon. So I think that that's absolutely on the list of therapeutics.
When you say, Sohail, that your job in PEDAL is that, so we have the trial, your job is sort of the pre-work to take the drugs to the trial. When you say that's kind of your job, you're kind of the prep guy, you're the preclinical.
So my job used to be mostly discovering targets and bringing it forward through some of the early preclinical work. And the idea was that you discover, you validate, and you bring it forward in a sort of preclinical, and then hand it over to someone to take the next step. The problem has been that until recently, it's been very challenging because no drug company is interested in developing anything that is pediatric related. Yes, my job has been mostly in the discovery, but frankly, because of the lack of opportunities, we're actually developing some of these, trying to move it into clinical arena, hoping that someone will come and take that part from us and move it forward for us.
And then Dr. Todd Cooper at Seattle Children's is actually, what would you call him? So his role is he's developing the whole protocol, isn't he?
He's a clinical lead. So he basically oversees how the drugs that we're bringing into the PEDAL they move into the clinical space and clinical trial.
Great. Oh, it looks like Will has a question.
Yeah, really very interesting talk and very, very inspiring. Questions actually for both of you guys. I mean, one of the things that you highlighted, I run into in my own practice with adults and adult women, and that is finding not only the interest, I mean, because the passion is obviously there, but the interest in the financial support with funding these trials. I mean, I know our collaborative group, and I'm sure the pediatric oncology group, I mean, we had to, with the economy doing what it did, we literally had to combine forces in order to, get any research done. And we actually really had to incorporate pharma way more than we had ever done in the past. And I know there was a little bit of a bitter taste with that, but quite frankly, and especially now, there is no other way to really fund our research other than that. And it breaks my heart to listen to, so it's more of a comment, it's, we fall so far short of some of the other more well-funded, cancers, breast cancer, colon cancer, Gynecologic cancers that I take care of really are kind of almost, well, I thought they were the redheaded stepchildren, but I mean, pediatric cancers sound like you guys struggle even more.
Mhm.
And I often feel like we're sort of just basically looking for the leftovers. And I just think that some of you know, I'm a cancer doctor for a living, and I really wasn't aware of that kind of struggle that you guys had too. I mean, that's just so anyway, I really appreciate listening to this, and I think that was just a fabulous presentation. It needs to be out there. So,
Well, I can tell. Oh, go ahead. Go ahead, Sohail.
But Will, one thing that you brought up that you're able to fall back on, get the funding from pharma for some of your studies. That's where actually 60% of all cancer research is supported by pharma, 60%. And, you know, the other 40%, there's 30% by NIH and then 10% through philanthropy and such. The problem is in pediatrics, we don't have access to that 60%. And NIH also does not fund us appropriately. So the access to funding is far more limited. In a lot of my, especially when it comes to AML, because AML disease of older adults. So when we try to get funds from NCI, since the reviewers are all adult oncologists, the concern that they raise is like, why are you studying something so rare in, you know, in less than 18-year-olds when you can do all your studies in 80, 90-year-olds when there's lots of patients. So I think that the access to funds, as you brought up, it's really a substantial barrier to pediatric cancers in general, but things like AML in specific.
Well, I can say that Sohail and I worked together on a project that was a grassroots project. We needed to get $8 million worth of work done. And we were able to accomplish it in childhood AML. And really, it kind of came down to one key word, and that is collaboration. If you can get people to work together, and in this case, we got foundations to work together and parents and everybody else to pool their money together, then the government was sort of inspired to match us. And so this whole children's initiative is also very collaborative in nature. So there will be pharma, you know, pitching in with money. There'll be other foundations are stepping up to help. So LLS is really acting as a leader and convener to pull people together. So, you know, it's an opportunity to get something else big done in childhood cancer.
yeah, I think more people need to hear what you guys just said, because that is it.
All right, we have time for, I think, one more question, if there's any questions left. Oh, Fred, it looks like.
I'll ask one. Where, it's kind of a two-pronged question. Where you're trying to raise 100 million, the program's been going on for approximately a year and a half to 2 years within LLS. Where are you at in that process? Are we halfway done? Are we a third of the way done? And then the other one is, outside of monies, what are the other big things that you really are needing and looking for?
I'm going to let maybe Allison take the where are we plan versus actual. But I can tell you, you know, just that last little slide that I showed, you know, we definitely need individual support for the initiative or, you know, getting people involved in the LLS campaigns. If you know of other people who may be inspired by projects in children's health like this, and even ones that might be inspired, maybe they're inspired by global, because this is really a global initiative. So introductions to others, you know, we definitely need the support of corporations. I'm going to stop myself. There's one particular hospital that gets all the corporate donors, and I'm not going to talk about it. But we need one of those Domino pizzas, $100 million gifts. And I think this initiative deserves it. So if you know corporations, and even I'm going to specifically say Amazon there in the Pacific Northwest just gave a bunch of money to that particular hospital that's not anywhere near the Pacific Northwest. this is the type of initiative that they could help us fund. So corporates, we definitely need help with awareness, spreading the word on social media. If you have contacts, media opportunities, things like this, definitely any ideas you have are welcome because we need it all.
Thanks, Julie. In terms of where are we to date, I'm sorry, I don't have the exact number, so we will be sure to get you that in a follow-up to this event because I don't want to give you the wrong number. We're doing well. We certainly are on track to, I think that goes a 5-year initiative, and we are approaching it from all angles, as Julie has shared, in terms of, with corporations and foundations and individuals. We have our impact report shows the donors who have supported to date, and we'll share that as well. We're very proud of that. Oh, I might have the exact number. Let me just see. So we believe we're just shy of about 20 million to date. Is the number where we're about now. So we're tracking very well, but as Julie said, we need the word to get out there as you shared. More people should know about this because it is going to just change the face of pediatric cancer, and we need to get this done, and we will get this done.
And LLS didn't tell me to say this, but I'm going to say it. Obviously, COVID has hit all foundations tremendously. Look at all the events that have been canceled. And so, for this initiative to work, we rely on many different parts of the LLS, their legal team, advocacy, everybody. We need a healthy LLS and a strong LLS to be able to pull this off. So, I would say definitely, now in the time of COVID, it's even more important now than ever. To make sure that LLS is funded and strong so that we can push this over the goal line.
Well, thank you, Julie. Appreciate that. And Julie and Dr. Mishinchi, we're so grateful for you being with us today, for telling us all about this inspirational project. It is one of those things, I agree. I think it's so inspiring. I want to shout it from the rooftops. So thank you for being here with us. And I'm going to turn it back over to Jamie for final words, and then we'll be done.
I'm a little choked up with all this information that we got discussed. So really, I just get to say thank you. So thank you to everyone for joining us. Thank you, Dr. Mishinchi, for the work that you're doing. Julie, thank you for being here, helping us learn, sharing your story. Everyone here, if you have questions that are left out there or just you'd like to know more, Ronica and I are here. We're going to be reaching out to each of you individually to see how you'd like to help. Everything that was just talked about, awareness, all of that, again, we're here for you. We're going to be making those calls and making sure we're getting connected. And with that, we all get to enjoy our evenings and have dinner. So that is our event. Thank you so much.
Thank you, everyone.